Yes, we are live now.
Yeah, madam, we are live now. So we are starting. So good evening, doctors and all the participants. I, Dr. Suman, on behalf of Shield Healthcare, welcome you all in today's session on a very interesting topic, that is Oocyte developmental competency. And we have with us Dr. Shamspriti Patnaik, ma'am. Just it's my formal responsibility to introduce ma'am, although all you know ma'am very well. Madam is the consultant obstetrician and gynecologist, laparoscopic surgeon and infertility specialist from Shanti Memorial Hospital, Rourkela, Odisha, one of the pioneer IVF institute that you all know from Odisha. So with this short introduction, I request madam to take over the session. And meanwhile, I request all the participants who have joined from Shield Connect or YouTube, please drop your queries on the chat box of our page. So once the talk will be over, we can have a short chat with ma'am on this topic. So thank you very much, madam, once again for your valuable time to discuss this important topic. And over to you now for further questions. Thank you very much.
Thank you so much, Suman and Shield Healthcare, for this wonderful opportunity and platform, which I've always been getting to speak on wonderful topics. I hope these topics and on the Shield platform, so many professionals, our colleagues, juniors and seniors get benefited from it. And we also learn from each other's sessions and talks. Thank you again. So I think, can I share my screen and start?
Yeah, madam. Sure.
Okay. So has the full screen come?
Yeah, it is full screen. You can start.
Okay. So why would we speak about Oocyte developmental competency is because I think the seed is very, very important for the plant. And whether it's a oocyte or a sperms or whatever, I think we know the importance of the quality of the oocyte, the development of the oocyte, and always, as we know, the competent sperms and the competent oocytes win. So we have to treat at the grassroots level. We have to treat the basics. Then only we can achieve our good pregnancies, our healthy pregnancies, and a successful outcome for all of our infertility treatment or any other oocyte related problems as such. So this topic had been chosen by me because, as we know, as infertility specialist or even as gynecologist, due to various menstrual disorders in various age groups, we do find a problem with the oocyte, the development, the number, the quality, and various other factors. I think it's very, very important we understand the physiology, the pathophysiology, and the research and the changes and what we are getting to know, and how science is also advanced in this sphere, so that we can get a wonderful oocytes, and we can help the women of all age groups to um, decide how the reproductive life, the menstrual life, and their womanhood can be. So without wasting much time, moving forward, as we all know, one second. Yeah. These are the basics of the cell division, the meiosis. We have been reading this since, I think, class 12 with our biology. We know this well, but it's very, very important to keep our basics strong. So it happens in the sex cells, the egg and the sperm. And we can see here the oogonium, which is 2N. Mitosis happens. Again, the primary site remains 2N. It arrests in the prophase 1. Then again, meiosis continues. We have less of it, half of it. Polar body takes 1N, and the secondary oocyte takes 1N, which arrests in the metaphase 2. Then ovulation, of course, with the sperm entry. The 1N, again, meiosis happens, fertilization. We get a diploid number again with a fertilized egg, and the polar body takes away the half of it. So after puberty, we can see the meiosis, ovulation, and again meiosis, fertilization. Before birth, we can always have this thing, as we can see, the arrest in the prophase 1 with the primary oocytes. So this is the basic that we have to keep in the back of our mind in our this thing before we think of other things in the oogenesis and spermatogenesis also. Cell division meiosis, as we already saw in that flow chart, it happens in the germ cells or the sex cells, egg and the sperm. Reductive division, as we have already seen, generates haploid gametes in the egg and the sperm. Two stages are there, meiosis 1 and meiosis 2, as we've already seen. Meiosis 1 separates the pair of the homologous chromosomes, reduces the cell from diploid to haploid, produces two haploid daughter cells. Meiosis 2, it separates each chromosome into chromatids, produces four haploid cells. I think this is the basic that we need to remember. What happens in meiosis 1 and meiosis 2. So this is again another wonderful pictorial depiction of it. The interphase and meiosis 1 having prophase 1, metaphase 1, anaphase 1, then telophase 1. Then interkinesis occurs. Then in meiosis 2, again we have the prophase stage, we have the metaphase stage, anaphase, then cytokinesis and telophase 2. So we can see here by the end we get four haploid cells as we've already discussed previously. In meiosis 2, each chromosome is separated into chromatids and four haploid cells are formed. Factors affecting the ART success rates. Of course, we know there's a male factor, there's a female factor, there are combined factors also. Male factor, of course, very, very important, OATS or oligoasthenoteratospermia, and B, sperm DNA fragmentation, very, very important in that aspect, but only in specific cases like recurrent pregnancy loss and others. Female factor, we all know poor ovarian response, a very big challenge for all the infertility specialists. Failed implantation, poor oocyte quality, poor oocyte developmental competence. So here is what our topic is. It's poor oocyte developmental competence that we are going to talk of. So oocyte, secondary oocyte or ovum, whatever. And oocyte is the simplest of the terms. It's an immature egg cell. And oocyte is produced in the ovary during female gametogenesis. Oogenesis, it's the process of formation of mature female gamete in the ovary of the females. And as we all know, it is known as oogenesis. The mature egg that comes out after ovulation is called the secondary oocyte or the ovum. So this is how we know the difference between what is oocyte, what is oogenesis, and what is a secondary oocyte or an ovum. What about M2 oocytes? What are they? The ovum or the secondary oocyte that comes out after ovulation is also called the M2 oocyte. Then why the name M2? In that ovum, the second meiotic cell division, meiosis 2, is not completed. The second meiotic division is halted or stopped at metaphase 2 stage, hence the name M2. The M2 oocyte comes to the fallopian tube when a sperm enters the M2 oocyte, then immediately the meiosis 2 cell division is completed and the sperm fertilizes the egg. The fertilized egg becomes a zygote, then a blastocyst, and then, as we all know, the different developmental stages into a fetus or a baby. So these are the basics that we have to keep in our mind. Why is it called an M2 oocyte? Where the arrest happens and what happens in the fallopian tube and after fertilization. Oogenesis starts with the process of developing primary oocytes, which occurs via transformation of the oogonia into primary oocyte, a process known as oocytogenesis. It is complete either before or shortly after birth. As we saw that flow chart, that what happened before birth and what happened after puberty. So we have our primary oocytes before or shortly after birth, and that is oocytogenesis. Primary oocytes reach their maximum development at around 20 weeks of gestational age, when approximately 7 million primary oocytes have been created. However, at birth, this number has already been reduced to approximately 1 to 2 million. The process begins at prenatal age. It stops at prophase 1. After menarche, that is after puberty, these cells then continue to develop, although only a few do so in every menstrual cycle. So the stop, we have it at prophase 1, then everything else happens after puberty. The development of oogenesis here. The process of oogenesis starts in the fetal ovaries with the development of oogonia from primordial germ cells. As we all know, the PGCs are primordial germ cells, is where from the development of the oogonia happens. They are formed during fetal development and they divide via mitosis. In other words, primary oocytes reach their maximum development at 20 weeks of gestation, as we've already mentioned that thing. We have it around 7-8 millions, but by birth, it again is reduced to 1 to 2 million. Then further with age, we know how, what is the decrement and what is the rate of decline with particular age. Oocytes are commonly divided into primary and secondary, and we have known the division of it. The egg cell's development actually begins before a female is born, when a diploid cell in each follicle begins a meiosis. The result is a primary oocyte, a diploid cell that is in the prophase stage of meiosis 1. At this stage, the process pauses. Some of the oocytes disintegrate, and by the time a human female reaches puberty, her ovaries contain about 400,000 follicles only, or 4 lakh follicles only. Beginning at puberty and occurring approximately every 28 days, hormones cause one follicle and the oocyte within it to mature. So this happens in every menstrual cycle, and a woman has so many thousands of menstrual cycles over the period of time, and that is how the age-related decline occurs of the follicles. This produces the secondary oocyte, commonly called the egg or the ovum. The secondary oocyte is released when the follicle breaks open during a process called ovulation. Again, development of oogenesis. Meiosis 2 is not completed unless the egg is penetrated by a sperm cell. As soon as this occurs, the secondary oocyte undergoes its final meiotic division. This forms the ovum, the mature egg cell with a haploid nucleus that is capable of fusing with the sperm nucleus. In that flowchart or the pictorial depiction, we already saw what I was talking about 2n and 1n and how it differentiates. I would quickly go back to that to show you what we are discussing in the various slides. Again, diploid stays before birth in the mitosis phase. Then when meiosis keeps on happening, so we have a haploid stage coming, secondary oocyte, which arrests at metaphase 2. Ovulation happens, sperm entry happens, again meiosis occurs and fertilization, and a diploid fertilized egg again is formed. So the process of oogenesis, as we can see here, the primordial follicles containing the primary oocytes at birth, no further development until sexual maturity. We can see the primary oocytes here in a line. Then we have the intervention of FSH, LH secretion at sexual maturity. Slowly we can see the primary oocytes changing into secondary oocyte and further early primary follicle, secondary follicle, Graafian follicle containing secondary oocyte, then ovulation. And then, as we all know, we have our corpus luteum of pregnancy and then corpus albicans, if not, no fertilization. And we can here see even the histopathological changes in the oocyte and how the ovulation is occurring. So if we have this picture in our mind always, we have our basics correct. We know what is happening and where the intervention is going to happen and which stage our drugs are going to act on, or which stage we are going to monitor the development of the oocyte and grading of the oocytes. So by this time secondary follicle is formed, the first meiotic division is completed. By the time the Graafian follicle containing secondary oocyte is formed, the second meiotic division starts. So this is how we remember with that flow chart, and this how it happens on the oocytes. Now coming, what we keep on saying to our patients in simple words, the quality and quantity of your egg. Sorry, the oocyte quantity alone doesn't ensure fertilization. The oocyte quality alone doesn't ensure fertilization. The woman's age is 30, but her eggs look like that of a 40-year-old woman. We all do face such cases in our OPD every now and then. It is the oocyte developmental competence that decides and ensures fertilization and blastocyst formation. So we have to keep in mind not always the age, not always the quantity and quality of the egg, but the developmental competence of an oocyte. As we all know, it is survival of the fittest, Charles Darwin theory. It works everywhere in this nature's creation. Competence. Cell-to-cell communication from the earliest stages of development through the adult. The cell behaviors such as adhesion, migration, differentiation, and division are regulated by signals from one cell and being received by another cell. These interactions are what allow organs to be constructed, like the development of the vertebrate eye. In the vertebrate eye, the light is transmitted through the transparent corneal tissue and focused by the lens tissue, and eventually impinging on the tissue of the neural retina. So thereby causing them to change their shape, mitotic rate of it. So this is an example in which we can see that there are two components to every induction interaction, the inducer and the responder. As we know, every action has a reaction. It's similar to that. So the two components are the inducer and the responder. So from this, what do we know? What do we mean by competence of a cell? So with various examples, we have now understood how a cell becomes competent or non-competent. Coming to the history of this topic and research in this field, in 1940, Waddington introduced the concept of competence. The ability of the cells to respond to a specific inductive signal is called competence. Again, inducer and responder here. It can occur through appropriate receptor or component of signaling pathway. The competence is required for proper growth and differentiation of the embryo, and it occurs in gastrula stage. The ability of a female gamete to mature into an egg with its potential to be fertilized and sustain an embryo development to the blastocyst stage. So we need it to go to a particular stage. It's not just at a certain stage. So the competence is the entire process of the maturity of the egg to be fertilized and then the embryo to be developed into the blastocyst phase. In some cases, the definition is even broadened to include the potential to sustain pregnancy after a live birth. So, of course, all we want is a live birth, a good pregnancy, a good clinical pregnancy rate, a good take-home baby rate. So, we need a live birth. So, our oocyte would finally be competent when we deliver a healthy, good baby to our couples. So, that is when an oocyte is going to win, or that is when any gamete is going to win. What is the typical structure of the oocyte which we should have in our mind? We have been studying it since our 12 boards or whatever in our botany, zoology, and everywhere, a typical cell, but we still need to remember it. We have the cytoplasm. The oocytes are rich in cytoplasm, which contains many types of molecules to nourish the cell early in development. Every now and then we have a new molecule, a new drug coming, which would increase your oocyte quality as claimed by pharma companies. So we are blindly writing so many drugs, but if we understand which drug is important for which patient, I think this is where the basics and the physiology comes. Nucleus, it's during the primary oocyte stage of oogenesis, the nucleus is called a germinal vesicle. Mitochondria plays vital role in oocyte maturation, fertilization, embryo development, and controls the embryonic metabolism and apoptotic events. Ribosomes, they are required for the translation of the proteins. Polar body is a small haploid cell that is formed concomitantly. As we saw in that flow chart, we have a polar body coming out every 2 meiosis stages as an egg cell during oogenesis, but it generally does not have the ability to be fertilized. The zona pellucida, it's the thick transparent membrane surrounding a mammalian ovum before fertilization. The factors affecting oocyte developmental competence. Again, we need to remember this very, very well, because this is where we have to find out which woman is having which factor leading to her incompetent oocyte. Dark zona pellucida, a large perivitellin space, telomere shortening, granular cytoplasm, improper meiotic cell division or arrest of meiotic division, spindle dysmorphology, lack of mitochondrial energy, lack of AMH. So these are the things which we have to keep in our mind. We do give drugs to increase the mitochondrial energy, to take care of other things, lack of AMH and others, but we also have to remember of the other 6 factors which we have written up, because we concentrate only on the lower 2 factors which you can see here. So we need to think of spindle dysmorphology also, improper meiotic cell division or the arrest, a granular cytoplasm, a telomere shortening, a large perivitellin space, or a dark zona pellucida. So we need to remember each and every factor. So here we can say the dark zona pellucida, this is a pictorial depiction, how to differentiate here. The perivitellin space, it is the space between the zona pellucida and the cell membrane of the egg. Here we can see the orange outline here, perivitelin space, should not be too large or wide, as it may cause multiple sperms to enter the ovum and fail the fertilization. So it has to be optimum so that we have our one winner there. Here is a depiction of the telomere shortening. This is the chromosome, as we can see, and the telomeres at the ends. So the short telomeres definitely affect, and this is where we find the defective oocyte. Predictive value of the oocyte morphology in IVF. So how do we predict about the oocyte morphology? In normal process where oocyte maturation occurs as a result of a long and meticulous natural selection process, in IVF, owing to different treatment strategies, there is a varying degree of development of oocytes. And I believe it's very, very difficult to predict the value of an oocyte morphology in IVF. But definitely we can. How about the assessment? How are we going to do it? The quality of the oocyte is determined not only by the nuclear and mitochondrial genome, but the microenvironment provided by the ovary and the pre-ovulatory follicle that can modify the transcription and translation. So that is where the microenvironment of the ovary and the pre-ovulatory follicle status comes into play, because it's not just the nucleus, it's not just the mitochondrial genome. Owing to the complex picture, it is highly unlikely that a single factor, characteristic, or a mechanism can adequately indicate the proper developmental competence of oocyte. So we have to take into consideration all the factors, as I said, all the 8 factors there, or in the structure of the oocyte, everything, and the process that we are having inside the transcription and translation also. Accordingly, to obtain a full information about the oocyte quality, a detailed and non-invasive analysis of markers would be required. We know every now and then we have research coming up, a new reserve marker, quality marker, quantity marker is coming up. So I think it is not just one factor which we need to consider, not just the AFC, not just the AMH, not just the microscopic picture. I think we have to correlate clinically each and every factor to decide our competent oocytes and which is the winner that we are going to choose and put our money on, like on a race in the horse. Gives important information with regard to the subsequent developmental ability of the driving embryo. So what is the importance of this? So it is, again, as I said, the oocyte competence matters till the end of the pregnancy, till the couple is going to take a baby home. But it is definitely about the development of the embryo that we are concerned about, a good, competent embryo, which would sustain throughout pregnancy. It helps to reduce the number of the inseminated oocytes and the number of supernumerary embryos. So that is where the selection or the good morphology or the assessment of oocyte competence comes here. It helps to avoid inseminating bad quality oocytes, potentially at risk of chromosomal abnormalities. So we need to get rid of our chromosomal abnormalities, our bad quality oocytes, or multiple number of inseminated oocytes or supernumerary embryos. So it is important for all the aspects. And of course, to get a good embryo and a good baby. What are the various oocyte quality assessments, which we have already discussed in bits and pieces? To summarize all of it, the morphological oocyte development is based on the aspect of as what are the things that we look for? The cumulus corona cells. If denudation is performed, oocyte morphology, a rapid evaluation using an inverted microscope is also performed after denudation. So we see the cytoplasm, we see the perivitelin space, the first polar body, the zona pellucida. It provides superficial but approximate information about the stage of the development and the quality of the oocyte. So this is what we are going to look for under our microscope, a few factors which we have already discussed. Factors affecting the oocyte developmental competency, again, lack of AMH, a prominent factor for poor oocyte competency, lack of MAPK or AKT signaling. This pathway inhibits meiotic progression of oocytes. So this is where this pathway has an importance. The spindle dysmorphology, the meiotic arrest causes sequential disruption of spindle assembly and chromosomal alignment. So we have to be very careful about the dysmorphology of the spindle Also, telomere shortening again, it increases oocyte aging, leading to large perivitellin space, darkened zona pellucida, and granularity of the cytoplasm. Lack of mitochondrial energy, it leads to depleted antioxidant defense. So, the increase in reactive oxygen species and oxidation. So now how this was all about the assessment that we were talking about. What are the factors that affect the competence of it? We have been discussing it again and again. So how to improve the oocyte developmental competency? So how to take care of lack of AMH? It exhibits that a vitamin D3 cholecalciferol has the ability to increase AMH. There are various drugs and molecules that have come up to increase AMH. Polycosanol opens up the vitamin D receptor and enhances vitamin D3 activity in cells, helping in ovarian steroidogenesis and gonadotropin to stimulate good oocytes. Vitamin D3 receptors are found throughout the reproductive tract. Zinc sulfate monohydrate is vital for increasing the vitamin D3 receptor function. How do we take care of the lack of MAPK or AKT signaling? Melatonin enhances the MAPK or AKT pathway, preventing meiotic arrest and progression towards metaphase 2 or M2 oocytes. So this is where melatonin comes into action. So we have nowadays coming various molecules coming saying we have this much cholecalciferol, we have this much zinc sulfate, we have this much melatonin, we have this much tryptophan. So what do these molecules act on and how do they increase the oocyte competency is what we need to know. L-tryptophan is a specific amino acid that can endogenously produce melatonin. So that is the reason why or how MAPK-AKT signaling is taken care of. How to tackle spindle dysmorphology now? DHEA, another wonderful molecule in all the drugs that we find to increase the competence. DHEA corrects the spindle dysmorphology and helps in chromosomal alignment, facilitating the oocyte competency. Dihydroepiandrosterone, this is how it acts. Gamma tocotrienol, which is 60 times more bioactive than conventional vitamin E, increases enzyme telomerase activity. It prevents the telomere shortening and it keeps the oocyte young, ensures a transparent zona pellucida, and reduces large perivitellin space. So that is how tocotrienol takes care of the telomere shortening part. How do we tackle the lack of mitochondrial energy? Here where we have coenzyme Q10, I think it is there in all the drugs that we prescribe, male, female, whatever. A unique fusion of coenzyme Q10 and beta carotene provides high energy quenching of the singlet oxygen, preventing DNA breaks in the oocytes. So that is how it acts. So we have various DNA breaks and these two molecules, they provide high energy for the quenching. So before going there, I would like to say ki roughly in our OPD, what we do an AMH, we do an AFC, we see the age of the patient, we see what are the other factors, a previous history of how many failures of pregnancy, how many recurrent pregnancy losses or implantation losses. So that is how we make up in our mind that definitely this woman is not having competent oocytes. So it does happen by seeing various multiple factors. We do prescribe women for 2 months, 3 months, our various drugs having DHEA, tocotrienol, coenzyme Q, even for men, they do have an effect. So I think it's a holistic approach. It's a combined approach to take care of each and every factor which is affecting the oocyte competency. Because the research and science has gone so ahead, there is no harm in doing it. And there are many sessions, many debates, many conferences which are saying that what is the importance of these drugs? Do they really help? I think it definitely adds up to it. They may be adjuvants or whatever, but they definitely help your oocyte competency and other factors. But of course, the various other preventive factors is information about the age, the reproductive health, the reproductive age of a woman. That also makes a lot of difference. And various other factors of competency, any other surgical abuse or any other surgeries and all, which also may not correlate with the age and other factors. So we need to see various factors which decrease the AMH, which decrease the oocyte competency of a woman. and likewise of the other gamete also. So summarizing this, the oocyte developmental competency is one of the prime factors in IVF, because that is, I think, directly proportional to the success rate or a clinical pregnancy rate or a take home baby rate. Lack of AMH or impaired MAPK-AKT signaling, spindle dysmorphology, telomere shortening, and lack of mitochondrial energy, they contribute to a significant association in oocyte developmental competency. This is what we have researched till now. As we all know, there are several other studies and researches which are still trying to know. Despite correcting all of this, also we have failures because nobody has 100% success rate. And I was astonished when a few IVF centers are claiming 70-80% IVF success rate. I don't know what rate are they talking of. They're talking about the implantation rate or what rate, but I think we believe our success is only when a couple takes a baby home. So through this, I would like to give a message to all the aspiring infertility specialists or the already established people. It is really disheartening to see the false numbers, the false rates, the false success rates for competition, or to keep yourself up in the market. That's not the correct thing. I think if we go down to our basics, if we keep our respect to our science, respect to our um, research, or even our studies, I think with that we can increase our success rate, instead of simply claiming that, oh, yes, we got a positive UPT, we got a positive pregnancy rate. I think that is not the success, because again, as we said, the oocyte developmental competency can be broadened up to till a baby is born. That is when your oocyte is going to win. So till the battle is not won, I think we should not give wrong numbers, wrong estimates, and wrong hopes to people. And we need to prevent the failure or the of an IVF cycle or any other cycle, even for a TSI or an IVF or whatever. Oocyte developmental competency matters for every infertility treatment, not just IVF. So the various nutraceuticals, including polycosanol, gamma-tocotrienol, DHEA, coenzyme Q10, tryptophan, have a significant role. There are various other molecules, some claiming this amount of or this milligram of melatonin is better, some claiming this amount of DHEA is better. So again, as I said, it's a huge field of research, still a lot of loopholes there, still a lot of factors where unexplained infertility comes into it. So oocyte developmental competency has to be explored even more at the genomic level, at the proteomic level. So I think I would have been able to tell people, or discuss with people at least, key what is the importance of quality over quantity. So for every factor, for that matter, it is not the numbers we show in our center, it is about the good healthy babies. And just putting a smile on one couple is, I think, makes your day, instead of false smiles on 100 couples. So I think the real happiness lies in the quality of any job, any profession, or any place. So that is where you can correlate about the oocyte quality. And how do you keep your oocytes competent? Of course, lifestyle modification, making aware the women of their reproductive age or their declining ovarian reserve or competency, or preventing a few unnecessary ovarian surgeries or other traumas which would lead to decreased oocyte competence. These are all the various factors which a gynecologist has to keep in mind. Not even an infertility specialist, a general gynecologist, which a woman goes, or a girl goes from her teenage years. I think that has to be taken care of. And abuse with various drugs and all have to be avoided. And it is a duty from the beginning till the end to protect the reproductive health of a woman. Thank you so much. I think I have been able to explain the various factors, and I would be open to questions, and I would like to elaborate if any other aspect, because I didn't want to enlarge it much. I wanted to keep it just to the competency and the quality of the oocyte and how it affects, because it's a huge science, as we all know, and it's very difficult to get into the minute details. It's just a broad aspect of it. So I'll be open to questions if possible.
Thank you. Thank you very much, ma'am, for this elaborative discussion on this Oocyte developmental competency. Just to ask one thing, ma'am, whether is there any recommendation means when you used to check this Oocyte competency, means what are the backgrounds or history as you already mentioned. So is there any specific things that you check to move forward with the developmental competency checking? What
See,
is your opinion?
definitely the first candidates would be recurrent pregnancy loss or or previous IV failures or various age factor or anything else. As I have already discussed those factors, that is where oocyte competency comes into play. But invariably, in general, we do prescribe like an empirically, to increase the oocyte quality, because that's the first thing that comes into the mind when a woman is not conceiving, that there is something wrong with the quality and the competency of the oocyte. So I think it's for every patient is when we think, and but it depends upon at which stage or how many procedures or treatment or thing the woman has gone through to prescribe all the tests or all the markers. So we need to be vigilant there. But of course, oocyte competency is there from day one in the back of our mind for every woman who's trying to conceive.
Thank you. Thank you very much, ma'am. And in case of this Oocyte developmental competency, so what are the means factors you used to check, or what are the primary treatment when you get a result that there is some problem in this Oocyte? So what is the primary treatment approach for them?
As we said, like empirically, all these drugs and all that, but then again, our morphological assessment is very important. Our selection of the oocytes are important for having good grading of the embryos. I think at every stage, the competency has to be checked, and we would try to improve the competency. So it's not just one. I think at every stage, we are going to take care of it.
That means throughout the entire IVF process.
Entire IVF process.
Yes. So thank you very much,
And
ma'am.
even not
Yes.
for IVF, even just for an ovulation induction and other things, when we're seeing the
Oh,
factors and we predict that the oocyte competency would be less. So there also empirically we are writing all these drugs which have all these things to increase the oocyte competence. We do write, if we have in our picture poor ovarian reserve or a repeated pregnancy loss or anything, we do give these nutraceuticals, as you know, in general. But then, of course, for other induction factors are different, but the adjuvants and other things are always given in a few factors to maintain or predicting a low competency, even in other normal cycles, not just IVF.
yes. So thank you very much, ma'am. What I understood that this oocyte developmental competency is very much needed, not only in case of IVF, but also in case of ovulation induction also. That time also you need to
In
check how
any time, a
oocyte
oocyte that we are expecting an oocyte to develop into a good baby, I think
Mhm.
that is where competence comes into play, not just IVF.
So thank you very much, ma'am, for this nice and elaborative discussion on this very important topic. And we'll be very happy for the future topics with you.